Hello, and thank you for watching this PEDRA-sponsored webinar, New Developments in Patients with Epidermolysis Bullosa, hosted in partnership with Amryt Pharma. An overview of our program. Dr. John Browning will speak first, followed by Dr. Lara Wine Lee. A moderated session will follow Dr. Wine Lee's presentation. I'd like to introduce your speakers. Dr. John Browning is Assistant Professor of Pediatrics and Dermatology at Baylor College of Medicine, Adjunct Faculty at University of Texas, San Antonio, and UIW Medical School. He's also the Chief of Dermatology at Children's Hospital, San Antonio. I'd like to introduce Dr. Lara Wine Lee. She's Director of Clinical Research in the Department of Dermatology at the Medical University of South Carolina, Associate Residency Program Director, and the Director of Pediatric Dermatology Fellowship. Here's our disclaimer for the evening. Information provided is non-promotional scientific purposes only and contains information on a product and indication that is currently under investigation and have not been approved by the regulatory authorities. The information contained may not be construed as medical advice and is not intended to replace medical advice offered by physicians. With that, I'll turn it over to Dr. Browning.
Well, thank you, Jen, and thank you everybody for just this opportunity to get to talk about EB. It's, I think, such a subject so near and dear to all of our hearts as pediatric dermatologists and as investigators, hoping to help people of all ages with this condition. So this is just a very, kind of bird's eye view of EB. And, I think it's a helpful backdrop as we talk about this new product that Dr. Wine Lee and myself were both investigators for. But as we all know, EB is a rare, devastating, heterogeneous group of genetic disorders, and it can range from people with EB simplex that have a few blisters to even none at all as they get older, to those with junctional or dystrophic EB, which you can see these pictures here, representative of the more severe forms of EB. So can really be quite a heterogeneous mix. And I think, just the key feature of all types of EB is mechanical fragility of epithelial surfaces, most notably the skin. Of course, that's what we're going to see as dermatologists, but we know as well that it can affect the esophagus and the urethra and other epithelial surfaces as well. And patients with these disorders experience blistering of the skin in response to minor trauma or friction. So what really doesn't affect the vast majority of people can lead to blistering or shearing of the skin or erosions very easily in those with EB. EB is quite rare. It's a devastating, again, heterogeneous group of genetic disorders, and there's really no predilection to gender, race, or ethnicity. It is genetic, so depending on the subtype, EB can be inherited in either an autosomal dominant or recessive fashion, and it is comprised of a number of subtypes that vary in clinical presentation as well as in incidence and prevalence. And as we all know, unfortunately, there is no cure for EB, and treatment of patients is heavily based on wound care and pain management, trying to keep them comfortable and minimize comorbidities. In terms of real-world estimates or prevalence and incidence of EB, I think this is really a great slide because this comes up all the time. Whenever I have a new EB family and we're kind of jumping into the world of EB together, it always comes up with the question of, well, how common is this? Well, we know that worldwide prevalence of all EB is 30 per million. The worldwide incidence of all cases of EB is 1 in 20,000. And 30% of these cases are junctional EB and dystrophic EB. So these are going to be the more severe cases. This translates into about 14,000 people worldwide living with dystrophic or junctional EB. And in the US, that's about 3,000 people with dystrophic or junctional EB. So very helpful numbers to be able to share as we help our patients and help our families understand this condition better. And as I mentioned earlier, there is a range of relative severity just depending on what the underlying genetic abnormality is. And you can see where the different types of EB occur in the skin. So with EB simplex, you've got involvement of the epidermis, and with junctional, the lamina lucida, lamina densa layers, and then dystrophic is the sublamina densa, and Kindler can affect the basal layer as well as the lamina lucida, lamina densa. And then in terms of characteristics, junctional is the least common, occurring at about 5% of the population. And this can be often a fatal diagnosis in infancy. It's characterized by extensive blistering, which can occur all over the body. Blisters will occur between the upper and lower layers of the skin, and the most problematic wounds can occur on the scalp and lower legs. And these are often characterized by bleeding, which I think can be one of the biggest problems with junctional EB. There can be dental enamel hypoplasia after the primary teeth have erupted, and these severe complications can become fatal in early life, particularly when you've got involvement of the airway with bleeding in the airway and compromise of the airway. As far as dystrophic EB, I think as pediatric dermatologists, a lot of us really know EB through our dystrophic patients because these are the patients that often we see the most of. It's more common than junctional, and the simplex and the dominant dystrophics often don't even come in to clinic, but particularly the recessive dystrophics are those patients that we see the most often. The blistering involves the hands, the feet, the knees, the elbows, really any area that's prone to trauma or pressure. The blisters will heal with scarring. Often there's milia around them. And most affected people have malformed fingernails and toenails. And so often, you won't even see nails when you're seeing these patients. And they can be lost completely. In really mild cases, sometimes the abnormal nails are the only thing that you'll notice. So if it's a dominant dystrophic EB patient, for instance, they may just have absent nails. EB simplex can be much more severe during the neonatal and infantile periods. And then often it improves with time. This type of EB is localized most often to the hands and feet, although you can have generalized forms as well, and relatively mild extracutaneous involvement. Onset of disease activity in EBS is usually at or shortly after birth, although there are many cases of patients with EBS who have presented with school sports or competitive sports, getting blisters more easily than their friends, as well as those entering the military who get blisters more easily with marching and heavy activity. Kindler is very rare. We're not even sure really what the frequency is, and it's difficult to diagnose. These kids often present with blisters early on in life, and looks like other cases of EB, but over time they'll develop photosensitivity, which can show up with poikiloderma, lentiginous. You can get atrophic scarring and nail dystrophy, and it can really mimic junctional EB, but with photosensitivity. And you can see it's quite rare. Compared to the other types, EB simplex is the most common type, 75% of all cases, and then dystrophic and junctional make up 25% of cases. So let's take a little closer look at junctional EB. And we talked about some of the features earlier, but you can see these widespread wounds that can occur in infancy with blistering occurring with minimal trauma. You can see the complete nail loss in intermediate junctional EB, the hypergranulation in intermediate junctional EB. This is often characterized by bleeding, and that can, as I mentioned earlier, that can really be a problem. The enamel hypoplasia, which occurs, and then alopecia can occur as well in intermediate junctional EB. And then looking at just the dystrophic form of EB, the wounds and scarring are common in both dominant and recessive dystrophic forms. Often you'll see some milia next to the scars. There's nail dystrophy that can occur, often with complete loss of the nails, like I mentioned earlier. And then squamous cell carcinoma can occur in sites of chronic scar and chronic damage, where you have repeat blisters and then healing and chronic wounds and scarring occur. Those are the areas where squamous cell carcinoma can occur. And I think that that's, really one of the greatest fears that our dystrophic patients have and their families have is when is this going to happen? Because we know it's only a matter of time. So it's very important to be aware of that. The pseudosyndactyly and severe RDEB can occur from that chronic scarring and can lead to the mitten deformity, which can be a very big problem, especially as people get older. And so it is important to make sure that the younger children and the babies are individually wrapping their fingers so that they can help minimize this comorbidity. You can see extensive blistering in these pictures, and these wounds leading to scarring and joint contractures, which can be disabling. And you can have, mild or more severe contractures, depending on how severe the underlying EB is. So how do we make the diagnosis? Well, it starts out as a clinical diagnosis. We suspect it when we see a patient with blisters. Often when we're called into the neonatal ICU, that's the ideal time to make the diagnosis if you do have that ability to do that. But of course, sometimes we encounter patients who never were quite diagnosed accurately, and we see them later and suspect it. But you're looking for skin blistering, superficial or profound, generalized, localized. Again, just depending on the subtype, it's very varied in terms of how it can look. Nail fragility, very common. And then contractures, strictures, dental involvement in certain subtypes, and other organ involvement, particularly in RDEB. Laboratory analysis would really be how you would confirm that diagnosis or confirm that clinical suspicion. And routine biopsy really has no utility, but doing immunohistochemistry is very helpful with the fluorescent labeled antibodies. So this is where you can look for the presence or absence of certain skin proteins. You can also do electron microscopy to look at the ultrastructures. Of course, both of these techniques really are dependent upon who is looking at the fluorescent antibodies, and then who's looking at your electron microscopy. So there is significant skill involved with both of those interpretations. But you will get rapid diagnostic turnaround, unlike with genetic testing, which can be difficult to do. It can be expensive, and it's really dependent on available resources, and it may take a while to get it back. Personally, I found genetic testing to be helpful when I can correlate it with my clinical and immunohistochemistry diagnosis. So that's when it's most helpful. Otherwise, if you're just doing genetic testing, but you don't have something else to correlate with, it can be difficult. You may find some red herrings in terms of what the underlying gene abnormalities are that are discovered. So with no cure for EB, wound management is fundamental priority for patients. This is to help keep them comfortable, to minimize infection, to prevent worsening of their disease. So relevant factors would be knowing the subtype of the disease, knowing what's to be expected in the future. Will there be improvement? Will there be worsening? What's the age of the patient? Is this a baby? Is this an older patient? What's their nutritional status? Do they have iron deficiency? Do they have zinc deficiency? These can really lead to problems with wound healing. What's their general state of health? What's their nutrition? Are they taking nutrition by mouth? Do they have a G tube? What are they doing to take care of themselves? Are they seeing hopefully a pediatrician or an internist who understands how to manage EB and can be part of your team? What's the availability of wound dressing? Do you have nonstick dressings available for them? How often can they get them, or are they having to just use Vaseline and gauze? What are they able to do? Are they using dressings at all? And then what's the optional involvement of nursing care at home? And again, just depending on the state they live in and their underlying health insurance, and unfortunately, often whether there's presence of a tracheostomy or a G tube may really determine whether there's nursing care available. What's the domestic environment like? Is it a clean home? Is it a safe home where they can stay? Are they getting the care that they need? With wound management, there's really no standard of care, and all you need to do is go poll a room full of EB families, and you'll find that the way that they treat wounds is all over the board, and what works for one person is not necessarily going to work for someone else. Wound dressings are changed about every other day or every 3 days at most. Adherent wound dressings are soaked with lukewarm water. This is often the most traumatic part of having EB for these patients. It can be very painful, very difficult, very, very time consuming. And then creams or ointments are administered on the wounds, and that can tend to adhere to the wound dressings, which can, again, make it difficult to remove if they're also adherent to the underlying skin. Use of topical emollients, including moisturizers for skincare, is definitely recommended so that this can help reduce the sticking to the wounds of the dressings. Equal parts of liquid paraffin and white soft paraffin are also used for peri-wound skincare, and overall greasy ointments like Vaseline or Aquaphor are used most frequently and can be helpful for the management of pruritus. And a patient caregiver survey revealed substantial EB burden and unmet needs, which found a wound burden to be a big problem. 32% of patients, 36% of caregivers stated that over 30% of the patient's body area was covered by wounds, and this can lead to pain. It can lead to prolonged wound care, dressing changes. It can also lead to bleeding and sticking to the bed sheets. Infections are a major problem. 75% of patients and 55% of caregivers reported that they changed the dressing on the same infected wound 1 to 3 times a day. That would be for those difficult chronic wounds that have purulence or other types of drainage. And then with quality of life, patients and caregivers reported that EB negatively impacts their daily activities, socialization, emotional well-being, and personal finances. So it just can impact many, many areas of life. Survey respondents identified most important factors for future treatments would be to reduce the number and severity of wounds, to decrease pain, and to reduce the risk of skin cancer. So for patients living with EB, larger wounds are associated with worse disease severity and quality of life, as well as anemia, osteoporosis, squamous cell skin cancer, and increased use of pain medication. So being able to allow chronic larger wounds to heal quickly and easily is a key target for these patients. So on that note, I'm going to turn this over to Dr. Wine Lee, and I'll be available at the end for questions as well.
Excellent. Thank you very much. Can everybody, I think, can hear me? And excellent, and now I have control. So I am here today. I'm going to actually talk first about the product that was tested in the trial, whose data we'll be looking at today. And it's really a very interesting formulation. This product, this oleogel, it is a derivative of birch bark that has multiple active ingredients. And these ingredients are in a sunflower oil base. When we look at the data, the placebo in the trial is the sunflower oil. So that's sort of interesting when we look at some of the data in the future that may have some kind of activity as well. But it's really interesting because the gel, it is a emulsifier, gets a kind of this very easy spreading and then thickens up after you've applied it, so that it forms a barrier in addition to having the active ingredients. This is actually a picture of the product here. So you'll see it's a single-use tube. It is a sterile product. So they use this during the dressing change, and it's a one-time use tube. And so each change, they would go to the number of tubes that they need. So there we go. And this birch bark extract has a good bit of data, not just in EB, but really in the whole field of wound healing, where it's been looked at both in vitro and in vivo at the different stages of wound healing. And so I think this here is a really, really important look. At the top of the slide, you'll see the different stages that we're all familiar with in wound healing. So the immediate inflammatory phase, the new tissue formation, so the cell migration, the changes in the cytoskeletal network, and then over weeks, the formation of the epidermal barrier. And at the bottom, we're highlighting some of the factors that the birch product is supposed to do, that has been shown in some of these studies, to work at actually each stages of this wound healing cascade. So in the beginning, in this immediate inflammatory phase, there is an upregulation of some of the inflammatory mediators that are pro-healing. And then the new tissue formation. So there is actually effects of the product on the keratinocyte cytoskeleton, as well as the migration properties. And then long-term, there does seem to be an enhancement of keratinocyte differentiation through some defined pathways. So really for those scientists out there, I think this is a very fascinating kind of cascade with a lot of different effects that there's some great references here on the bottom that you can really get into understanding what is happening. So let's look more specifically at the data. So this was a phase 3 placebo-controlled study looking at efficacy of safety and safety in EB. I'm going backwards. Okay, and this is the study design here. So in the screening and enrollment period, so first of all, I want to just note the number of enrolled patients was 223, making it a very large study for our rare disease. And the stratification, it was a 1-to-1 randomization between the placebo and the active product. And the stratification was done by the subtype of EB as well as the wound size. So trying to get matched populations across the two. The active phase here, the double blind, was 90 days with a primary endpoint of the proportion of patients that had complete closure of a target wound. So the next slide, we'll look at a little bit about selection, but the primary endpoint was a selected wound by the investigator, and that was assessed at 45 days. The patients at this point, after the 90 days double blind phase, had the option to enter the open label extension. And you can see 205 patients did enter that phase. So the demographics were very similar between the placebo, the control gel, and the oleogel. And I think there's a number of important things on this slide to note. So one, over 70% of the patients were in the pediatric population, so obviously of high interest to us here. But the characteristics amongst the groups of the control and the active product were very similar. The majority of patients did have recessive dystrophic EB, with really a much smaller number of dominant dystrophic and junctional EB patients. There's just a further look here, looking at the potentially a surrogate for nutritional status, but also again fairly well matched by looking at the BMI groups in the different patients. And then on the bottom, what's important to note is a little bit about these wounds. And the wounds that were selected were, as shown on the previous slide, they were of a certain size, so 10 square centimeters to 50 square centimeters. And they had to have been present for at least 21 days, but not more than 9 months. And amongst the group here, you can see fairly well matched with the average wound ages within the 30-day mark for both our placebo and our active product. And to give you a little bit more idea of what was assessed in this study, so this is just examples of different wounds. So you see the wound stratifications by size. And again, remember the randomization was done by wound size as well. And the baseline wounds, which were measured with this method using a camera system that traces out the wounds, the investigator traces out the wounds, and you really get a very, very excellent measurement of the size of the wound that you can follow throughout the study. And then here, looking at what the primary endpoint looked like. So this was complete closure of the target wounds. So the formal measurements being done on the selected target wound that was then followed throughout the course of the study. So the news here is that the primary endpoint was met, looking at that 45 days of the active product versus the control gel. The patients in both groups had improvement in or had wound closure, as shown in the percentages here. So 41% in the active group and then 29% in the control group. And so this was demonstrating a significant improvement with or higher number of wound closure with the active product. Here we stratify a little bit more about the target wounds, so the primary endpoint at this 45 days by subtype. And really, I think the important thing to note is that the vast majority of patients in the study were the recessive dystrophic patients. And so therefore, you can see most of the data is going to fall within this first box here with our patients, again, showing those similar results with a higher percentage of patients reaching the primary endpoint at 45 days. That result was not seen in the smaller groups. There's a little bit of a mismatch here in the dystrophic patients, again, a very small group and not as well matched, as well as another small group in our junctional patients. But going back to the initial slides, I think it's important to note that this is not thought to work by genotype, as it is a wound healing product. And we can, add that to something to think about in our discussion. So despite the prior slide showing by subtype, the primary endpoint was stronger in those recessive dystrophic patients, this here was looking at time to complete closure. So looking at the mean number of days from the baseline measurement to what was determined to be complete closure of the wound. And across subtypes, although not necessarily significant all the types, but you can see that the complete closure did occur sooner in those patients that were on active product. And this just takes out the data and says, okay, so after the 45 days, so the whole study period being that 90 days, was this, what was happening with the wounds? So it's important to note, though, that after a wound was closed, no further measurements were necessarily done, but that the improvement that was noted in the target wound size for these wounds did maintain throughout the 90 days. So any improvements were maintained throughout the course of the study. And then as secondary endpoints, so the product, the active or the placebo product, while the target wound that was selected by the investigator was the one that was measured, the product was actually applied to all the open wounds. And there was not an upper limit in the number of wounds or the size of the wounds that they could be applied to. And so the secondary measures were looking more at the total body wound surface, the body surface area, and then we'll look later, look here at the EB-DASI as well. This wasn't assessed as frequently in the study, study, but here at 30, 60, and 90 days, that you can see with the oleogel that there were improvements greater than the control gel for both your EB disease activity and your body surface area percentages. And that's the product listed here in blue. And again, these were noted about 30 days and were maintained with continued improvement up to the end of the study here at 90 days. And then another really, really critical secondary endpoint that was looked at in this study, and also emphasizing again that over 70% of the patients were pediatric patients, was looking at the procedural pain. So this was the pain that was associated with their standard dressing changes. So pain was assessed throughout the study. And if you see again here in blue, the active product, that there was a reported improvement in dressing change related pain based on this visual analog scale in patients assessed greater than 4 years old to actually use this scale. Just of note that the characteristics of pain were very similar. You can see at the top, very similar amount of pain that was reported in the placebo group versus the active group. And again, those effects were maintained throughout the course of the trial. Another really important endpoint or important symptom that we all really struggle with in the care of our EB patients is the itch associated with it. And so here is really kind of detailed information looking at different aspects of the scale of itch, so kind of different domains of itch. And the active medication versus the control gel in 4 of the 6 domains noted here. You can look at the duration, the severity, the frequency, and the distress associated with itch. And this is done in patients 14 and up. But you can see that there were improvements noted in itch in 4 of these 6 domains. In our younger patients, so in our patients between 4 and 13 years of age, both the control gel and the active gel did have improvements as itch, with the control gel being slightly favored, but these results did not reach significance. It was more of a trend that was seen. And so, very important here to look at the safety of this topical product. So the most frequently reported AEs were actually, quite similar across the groups. So as we all know, in caring for these patients, they have a very high rate of complications with all of their treatment. And this bore out in the trial. So about 80% of the patients reported some adverse event. The adverse events were rather similar between the active and the control gel. There was a slightly higher of these rated grade 2 AEs in the control gel, and the severe one favors slightly the active gel. This looks like it was mostly due to some episodes of anemia, but very similar rates of the AE leading to study withdrawal, but it was a very low number. So low number of patients overall, only 5 patients in the whole study withdrew from the study due to their AEs. And you can see at the top, just to kind of point out here, the numbers. So the anemia was slightly higher in the oleogel. I'm not sure that there's a specific explanation for that, but the 7.3% versus 3.5%. But the other one's very similar across the 2. What was interesting and also very important for all of us who care for EB was the infection rate. So overall, actually, I thought this to be a very, very low infection rate. If you're looking at the percentages of infections that were reported within the 90 days, this is such a frequent occurrence in our patients with EB. So the severity also was relatively mild. There weren't actually any infections that were deemed as life-threatening, and only 1 severe infection in the control group. But again, slightly higher number of infections of the moderate category in the control gel. And then looking also at a very low rate of serious adverse events, although a slightly higher number of serious events leading to study withdrawal in the oleogel group. One of these was actually thought to be related to the product. But again, a low number showing, across the study, just in general, low side effects for the product. So in summary, and I hope that this has really brought up some interesting questions, and I'm looking forward to a great discussion. This trial was the largest prospective controlled trial in the EB population, looking at our severe patients with dystrophic EB and junctional EB. The product did meet its endpoint of wound closure at 45 days versus the control gel. This was most pronounced in the recessive dystrophic patients, which made up the vast majority of the patients in this study. Overall, the reduction in the total wound size, so even prior to closure, wound size reduction was close to 60% as early as day 14. And that's a nice number to think about. The total wound burden also decreased over time, and that patients using the product were reported to have a greater reduction in pain associated with their dressing changes. Overall, very well tolerated, with a low number of serious adverse events and adverse events that were in line with the control product, and very few that led to withdrawal from the study. And so with that, I'm happy to open up discussion about the oleogel and this potentially very, very important advancements for our patients with EB.
Thank you so much for that, both of those excellent talks. Let's see if I can get Dr. Browning back on here. Let's see. So while we wait for some questions to come in, there was a lot of really fantastic, really meaty science in that presentation, Dr. Wine Lee. And I'm wondering if you can distill that sort of and give a message to our patients and caregivers. Like, what does this study mean for them exactly?
Well, I think there's sort of a number of highlights in this study for me. One is that this is potentially a wound healing product with applicability in EB that can be incorporated into their regular bandage routine. I'm not sure that I highlighted that enough in the presentation, but this was not something that they were required to change their wound care routine, as long as they did do their wound dressings at least every 4 days, which most of the patients, there's like just a huge variability. And so a lot of times that you test something and you change the way the patient does it, and that's very inconvenient for them. So, and it's very difficult. And actually, Dr. Browning and I were talking about this beforehand. It's much better when you feel like it can incorporate what they've already found work for them. So I think that's sort of number one. It's a product that can be incorporated in their other care that is ongoing. And number two, it really does represent some advancements that can aid in the wound healing, with both important to highlight the wound closure. So again, reducing that wound burden that came out from the survey as such an important part of the perception and the experience of living with EB, as well as that pain aspect. To me, that was just a very important part. Again, like Dr. Browning highlighted, one of the most difficult parts is that they're very critical wound healing products. Oh, Mike just joined us. Their wound dressings and all that is also one of the most anxiety-provoking parts of their care. And so to potentially be able to add something that was useful, I think is a really important advancement.
I agree. I mean, this is really exciting. One thing that just sort of stuck out to me was when you were talking about when the gel is applied, it sort of goes on nice and smoothly and then thickens over time as it's on the skin. And like, is that something that aids in the reduction of pain?
So I'm not sure I can answer that. And I probably perseverated on that because I found it to be so interesting as well.
Me too.
Yeah, it's really interesting. And, looked a lot into it and trying to understand how it works, but it's a gel. And then when you go to apply it, it liquefies and kind of spreads easier and then goes back to the gel. If I'm in my very simplistic view of the science behind that. And I think that's important because then it has the ability to act as a barrier. And so in the study, I mean, were no other products that were applied to the wounds. So if they had been applying another barrier like Vaseline or some other emollient, then always the concern then is that you're going to add something that diminishes another part of their routine that can be very effective. But the fact that it has that property to kind of act as a gel and act as a barrier, I think is a very, very important part of using it.
Dr. Browning, any comments here?
Yeah, no, I agree completely. I think that this, really product can give people hope about being able to allow those chronic wounds to heal faster and to give them comfort. I do think one of the questions was, how frequently would they need to apply it? And I think, the beauty is they can do it when they want to do it and part of their normal routine. It was not studied as a preventative for blisters, although certainly could be used as you might use any type of wound care product, or I'm sure many people will want to use it as a preventative, because it does sort of double act as the barrier. And then there was another question that had come up about, is the product being studied outside of EB as well? And does sunflower oil have its own potential wound healing properties? And can you use it on its own? So I do not know if it's being studied outside of EB. As far as I know, it is not, at least through Amryt, but I will defer to others regarding that. And then with sunflower oil, many of us who see kids have recommended sunflower oil for years as an emollient. It has been studied before. There are good papers on it that you can pull about using it just as an emollient. And often when people kind of balk at using petrolatum or Vaseline, which is, a petroleum derivative, petrolatum derivative, and they want, kind of that natural product, I'll often mention sunflower oil as a potential that they can use. And I found it to be better than coconut oil, and certainly a lot less irritating than olive oil. So I do think you can use it on its own, and you may want to pull some of those old papers. In fact, I think Larry Eichenfield might have his name might be on some of those papers from about 10 or 15 years ago.
My patients always tell me that sunflower oil is one of the things also that's highlighted in their their chat rooms, and is a product a lot of people like. Getting back to the question about marketed outside of EB. So there's a nice publication, which is referenced in one of the slides that was from that was done in 2019 in Dermatologic Therapy, talking about some of the prior investigations, some of the in vivo type of stuff that has been done with this. I believe that it is marketed already in Europe for just as a general wound healing product. So there were a number of phase 2 and phase 3 studies in general wound healing. So really, prior to kind of even the EB investigation, as I understand it.
Excellent. Feel free to ask those questions, folks. Keep them coming. So I know the study, the endpoint primarily was 45 days, and then you were monitoring patients at 90 days. What about beyond 90 days? What were patients reporting beyond 90 days?
So we don't have that data released yet,
Okay.
at least that I'm aware of. But if there was that open label extension, with which a good number of patients did enter, that was 24 months in length. So I'm sure we will, get some of that information long term.
Yeah, absolutely. Any word on anticipated cost yet?
I don't have one.
Yeah. Yeah. Let's see. Another question has come in with EB. can be difficult to recruit. So well done on your enrollment. That was quite a large enrollment. That's really exciting. Any tips for researchers in making trials accessible or other recommendations? We get this question a lot, like how do we enroll patients? How do we get access for our patients? Any advice there?
Well, I'll speak to that since we were talking about that. Actually, Dr. Wine Lee and I were talking about that right before we started. And I think that it is very difficult to recruit for EB studies. And you kind of have to choose your studies wisely, because you want to hopefully recruit for a good study. And it can be difficult if you have subjects that go into one study and have a bad experience, and they're not going to want to be part of another study. So of course that can be hard to know. Sometimes you don't know up front, how a product's going to be and whether it's going to be something that they like. But you should, think about that. Does this look like something really promising? And then I have found it easier to recruit from, kind of a larger geographic area than where I just have clinic. And so you can have, you can get the sponsor often to help pay for transportation. So that's something that you just have to ask about, is finding out, how those patients that may live one state away, how they can travel to your site, and then making that happen. And then word of mouth, especially in EB, it's such a small, tight-knit community. And so if somebody finds out about a study and they're, if it's a happy patient or a happy subject, you can always encourage them to, they can't really talk a whole lot about the product because it's under investigation, but, they can mention that they're in a study and that other people may want to call your site to be in the study.
The other thing that I could add, particularly with the rare disease trials, is partnering with the patient organizations. And so I think some of the rare disease trials that we've been most successful with have had a lot of those referrals because of support of those organizations. This can be really great. But yeah, these trials, you need to really recruit broadly and need to have the support to do so.
Absolutely. I'm so glad that you brought up partnering with the patient organizations, because they are very strong and they have the access to the patients, but they also have the daily understanding of just how awful this situation is. I had a question that I wanted to come back to while I think of it for a second here. So Dr. Wine Lee, could you just remind us how many patients were enrolled that were from the US?
So I do not have that
Okay.
information. So okay.
That's all
I don't
right.
have access to that.
Yeah. So as physicians and working in clinic, I mean, this is just listening to these talks, this sounds like pretty groundbreaking options. So as physicians in clinic, like I heard Dr. Browning say, this gives patients hope. Like, how does it make you feel, going into the clinic, knowing that this could get approved and this could be really impactful for your patients?
It's amazing just to finally actually have something that could be approved to treat EB, because right now there's nothing. So, and while this is a topical wound care product, it's not targeting the underlying genetic abnormalities, which we all hope to see at some point in our careers. It's still important. And just like in the world of atopic dermatitis, we can treat the inflammation now with new systemic options, but we're still needing to treat the underlying skin barrier abnormality with emollients and topicals. So it's exciting to have this product in the EB space.
I think that it's been so important for the families to actually know that there's an interest. I think that has been really, really remarkable, just to see that there are people that are approaching it. So, whether it's, like you said, some new advances, some research advances versus some of the pharmaceutical, it's really been very exciting. But it's a tool, and it's nice to always get new tools. I also, like that we're looking at something that necessarily is not necessarily genotype specific. And of note, not all of the patients in the study were genotyped, but it's truly a wound healing mechanism applied to this disease that's so important to us.
So, to your comment, Dr. Browning, how do we go from this wound treatment to actually treating or the underlying cause of this disease? Like, where is the research need to be right now to get from this point to really the end game?
Well, I think, one way is just making sure that our, patients are comfortable, they have improved quality of life, and they're living longer,
Mhm.
so that there'll be an opportunity to potentially treat the underlying genetic problem. So, I mean, just improving their quality of life and overall health with a product that's effective is really part of that. And this is just it's a wound care product. It helps wounds heal. Certainly, chronic wounds were studied in this trial, and so it helps those to heal faster. But it just opens that door to continue looking and continue investigating to really start targeting the underlying genetic abnormalities.
I think something that I didn't really focus on due to time, but this was actually done down to a very young age. So this was used in infants as well. And I think that's very exciting because to have some safety and efficacy data in our youngest age group, we don't have that in many things that we do in pediatric dermatology.
Yeah, absolutely. That's really important. This is a good question. How many tubes to use with wounds, and is there a limit?
So there was not a limit. And so that's kind of important to think about too, because many times when we test a topical product, there's a minimum BSA and there's a maximum BSA. And so when you're then broadening the idea of safety, with a potential for something like absorption, then you may be exceeding what was actually tested. So this was applied to all active wounds, although again, the target wound being the primary endpoint that we focus mostly on. And there was not then a limit in the number of products. There was specific instructions, and it was demonstrated to the patients about an application technique with how thick it should be as a standard. And they used the amount of product that they needed then to cover the wounds to those specifications.
Well, thank you both so much for taking the time. This has been a very exciting webinar with lots of very exciting information. Thank you for joining us. Thank you to Dr. John Browning and Dr. Lara Wine Lee for those magnificent presentations. Thank you to Amryt Pharma for sponsoring this webinar. For other webinars, please visit us at www.pedraresearch.org/education. If you have questions or would like to be connected with our speakers, please email me at info@pedraresearch.org. Be sure to follow us on Instagram, Facebook, Twitter, and YouTube, and LinkedIn. And you can also subscribe to our Pedra Pearls podcast, available in iTunes, Google Play, Spotify, and wherever you get your podcasts. We'll see you next time.